I would request Dr. Vismay Nayak, sir, to introduce our next speaker.
Yeah, so it's my pleasure to introduce Dr. Tejas Shah. He's from Sanjeevani Hospital, Mumbai, and he's a consultant diabetologist. And he'll be discussing about the newer WHO classification for diabetes. So over to you, Dr. Tejas.
A big thank you to the entire organizing team of SwasthyaCON and for having me here. I'm Dr. Tejas Shah from Mumbai, and I've been going to talk to you today about the new classification of diabetes. So this is the outline of my talk, how we'll be going through. Initially talking about the prevalence of type 2 diabetes and type 1, the purpose of classification, why we need a classification, going on to the timeline of classification systems, going back a bit into the history of what were the earlier classifications, challenges that we have with the current classification, and why do we need a new classification. Going on to a thought which has come up very, very recently, which talks about a beta-centric classification, and then going on to the present WHO and ADA 2020 classifications. So we all know that the prevalence and incidence of diabetes is huge. The epidemiology itself tells us that the numbers have been increasing all over the world. We need not go into the details of each number, but of course, the numbers are as high as more than 600 million at present, and the numbers are going to go on to more than 700 million by 2045. If you look at only the Asian countries itself and the Asian continent per se, again, the Southeast Asian population somewhere around more than 88 million in 2017, but going to as high as 150 million in 2040-45. India itself, as you know, is the diabetes capital of the world, where we have more than 70 million population already with diabetes. And so, as the number suggests, it's a epidemic, no doubt about that, and we need to understand the pathophysiology more and more. So the entire reason for classification is basically mainly that we have three aims. We need to understand that the hyperglycemia is the sole defect in any person with diabetes, but the patient with diabetes per se differs in terms of etiopathogenesis, it differs in terms of their presentations, they differ in terms of their age of presentation, etc. So, and that's then why we need basically a classification. So classification helps us per se in terms of guiding clinical care decisions. We need to understand what kind of or what kind of subtype of the person with diabetes is, and therefore according to which the treatment or a decision is going to change per se. Something that classification helps us is in terms of stimulating the research into etiopathology. Each diabetes though may have hyperglycemia, but they may differ in terms of their etiopathogenesis, and etiopathogenesis, as they differ, that is how the approach to the treatment will change. And thirdly, they provide a basis for epidemiological studies. There have been various studies which have been done in the past, which have looked into different prevalence and incidences of different types of diabetes. However, the subtype of diabetes that we know of have not been studied enough, and many times understanding the subtypes of diabetes and the epidemiological numbers overall helps us in deciding what kind of treatment we want to go ahead. So if you go back in history, 1965 was the first time when a classification for diabetes came in, which mainly used age as a diagnostic criteria. It looked at different age groups, starting off from youngest or the small or infantile to adult. Following which, in 1980 came the first widely accepted classification of diabetes, where it classified diabetes into non-NIDDM and IDDM, that is insulin dependent and non-insulin dependent, and also labeled them as type 1 and type 2. However, 1985 saw an updation of this same classification, and it removed the terms type 1 and type 2, but retained the classes as IDDM and NIDDM. In 1999, classification included different etiological types of diabetes, and it laid stress on the clinical stages of the disease. That means a person may have a type 1 or type 2, but may differ in terms of the stages that they present, and it laid stress on putting forward the clinical stages of the disease. All these classifications also had two additional classifications mainly, that was other forms of diabetes and also a gestational diabetes. And finally, in 2019, we have the classification based on clinical care, etiology, and epidemiology. So this is the first classification that I spoke about in 1965. It classified diabetes as infantile or childhood diabetes, where the onset was between ages 0 to 14. Young diabetic was onset between ages of 15 to 24, and adult onset diabetes was somewhere between ages of 25 to 64, and an elderly is an onset at the age of 65 years or older. In 1999, as I told you, the classification laid stress on the stages, basically classifying as type 1, which would be an autoimmune or an idiopathic. However, this autoimmune and idiopathic could pass through all the stages again. They could have a normal glucose tolerance progressing to IGT, not insulin requiring or insulin requiring for survival. Same way, type 2 diabetics could be predominantly having insulin resistance or predominantly maybe insulin secretory defect. Again, could be passing through all the stages, the other specific types, and the gestational diabetes. However, let us understand that limited knowledge exists at the time of crafting of current system, yielding definitions for type 1 and type 2 and LADA. Let us understand that a classification system is primarily meant to act as a navigation tool. We need to follow that navigation tool in order to help us reach our goal, in order to diagnose a person correctly, the kind of diabetes, and to decide on the correct line of treatment. However, whatever knowledge was present at that time, at the time of the older classification, it classified them as type 1, type 2, and LADA. But now what we know is that there is a lot of overlap between these different types of diabetes, and therefore this present classification has become more of an indistinct, ambiguous, and imprecise. This is a representation of primarily current parameters that are used but are inadequate to clearly distinguish any subforms of diabetes. Like it can differ in terms of age, where we use factors like age, we use factors like whether obese or non-obese, we use factors like whether presence of metabolic syndrome or no, genetic markers like HLA, or presence or absence of autoantibodies, presence of T cells, and whether a person has a low or high C-peptide, or whether there is an insulin requirement or no insulin requirement. But let us understand that the system does not clearly distinguish between a type 1 or type 2 or LADA sometimes, because over a period of time, the presentation of a person has changed. Up today, classically, a type 1 with antibodies positive and a low C-peptide was always thought to be type 1. But today we have presentations which might be different. A person may evolve over a period of time. A person with LADA, or it is called latent autoimmune diabetes, is not very clear whether he is a type 1 who is evolving and presenting late, or whether he is type 2 who has got a beta cell deficiency or beta cell destruction very early. And therefore, these subtypes need to be classified properly. A lot of thought has gone into one recent classification system, which is primarily based on the beta cell. We now know that the defect in diabetes is not purely only beta cell deficiency or an insulin resistance, but there are almost 11 distinct pathways which contribute to beta cell destruction or dysfunction or loss. And therefore, our treatment should be targeted primarily to specific pathways of hypoglycemia. And therefore, a proposal expands on an earlier model that described primarily 8 core defects of diabetes. What the new system suggests is that to be a more beta-centric model, where beta cell is considered to be the center of in the focus, and the entire classification is based on primarily the defect that causes the beta cell dysfunction. So apart from the 8 famous ominous octet that we know of, that is the insulin resistance being the culprit in case of liver, muscle, and adipose tissue, where there is also increased lipolysis. Kidneys may be playing a role in terms of increased glucose reabsorption, GI tract playing a role through decreasing creatine excess, brain through a neurotransmitter dysfunction. There are 3 more new areas of defects which are thought to be there. One is the gut microbiota, which is supposed to be playing a role, an abnormal microbiota possibly decreasing the GLP-1 secretion. There is the role of inflammation, which is supposed to be one of the factor now in diabetes, and there is a decreased amylin production, which is responsible maybe for an increased postprandial blood sugars happening in patients. So these 11 defects are supposed to play a role, and the entire classification is based on this 11 defects. And the same way, depending on the classification, depending on the defects that are there, you need to understand the therapies which are working on them. Like a brain dysfunction or a neurotransmitter dysfunction might respond better to a dopamine agonist with incretins or an appetite suppressants. An insulin resistant defect would do better on metformin TZDs. Similarly, the kidney defect would be should be treated with an SGLT2 inhibitor. A GLP agonist would work better, and an AGI in cases of an incretin defect. Similarly, a kind of or a probiotic or incretins and metformin working better on the gut microbiota. So the entire classification is based on a beta cell defect, and the entire treatment should be thereby based on the same. However, also what we know is that this model is not something very easy. The diagnostic tests that are required either are not standardized or not routinely available in clinical practice. Measurement of C-peptide, beta cell specific autoantibodies, markers of low-grade inflammation, and measures of insulin resistance and assay for beta cell mass are something which would be required, and they maybe are not in a direct access to most of the population sometimes. So a single classification system that we know of should primarily, as I told you earlier, should have solve three purposes. It should help us in clinical care in deciding the line of treatment. It should help us per se in the ethiopathology and the epidemiology. It should be internationally applicable. It should be readily available, clinical parameters and resources. They should be reliable per se, equitable, and feasible to implement. So this is the new classification of diabetes in 2019 that was came forward from WHO, primary classifying them as type 1 and type 2 that we already know of, type 1 being present in almost in less than 5% of the population, and type 2 being present in more than 90% of the population. The type 2 primarily having more of insulin resistance going on to the beta cell defect, and type 1 is primarily having a presence of autoantibodies but also having the total beta cell defect. There is another new form of diabetes which is now known as the hybrid form, which involves two categories. That is the slow evolving immune mediated form of diabetes and the ketosis prone type 2 diabetes. So the slow evolving immune mediated form primarily has three characteristics. Mainly, it is similar to what we know as LADA or latent autoimmune. It should have the presence of autoantibodies. There should be absence of autoantibodies. It is detected at the age of about 35, and there should be at least the presence of patient doing well on oral drugs for at least a period of 6 months to 1 year. So these are the characteristics of a person who could come into a slow evolving immune mediated form of adults. The other ketosis prone of type 2 diabetics is something which is seen in type 2 individuals who may present as type 2s but may have ketosis over a period of time. This is commonly seen in certain African countries, and patients are detected more from these countries, and it is another evolving type of diabetes that we are seeing now. The other specific types of diabetes mainly includes the monogenic diabetes. Monogenic diabetes could be again a defect of beta cell function or a defect in insulin action. Defect of beta cell function mainly is primarily then there is the disease of exocrine pancreas, which arises from any damage to the pancreas. There are endocrine disorders, the drug or chemical induced, the infections, the uncommon forms of immune mediated diabetes, and other genetic syndromes. There is another new entity which has come up that is called the unclassified diabetes. This is mainly used when there is not a clear diagnostic category, mainly close to any which would define diabetes into a particular type, and they have been put into this unclassified type. And hyperglycemia, which is first detected during pregnancy, which could be gestational, or it could be diabetes mellitus in pregnancy. The monogenic diabetes, as I told you, is primarily what we know as MODY, which could be arising due to a defect in the various genes. Mainly, the glucose defect in the GCK or glucokinase gene is lesser common, while the more common is the H1F1A and HNF4A. These primarily are important to diagnose because they mainly have, because of the defect in the gene, they have a defect in the SUR receptor, and they are the ones again who do very well on sulfonylureas. There is another monogenic diabetes, which is the pediatric neonatal diabetes, which is detected in the first 6 months of age. And again, it is something which is important to diagnose and not to be confused with type 1. And that's why the classification becomes very important here, because a defect in KCNG11 is what is seen in them, and it causes a defect in the SUR1 receptor, and thereby they do wonderfully well on sulfonylureas even and do not require insulin for their treatment. Similarly, there are other genetic forms of syndromes which are associated with diabetes. The monogenic defects in insulin action are the rarer type, but they again present like type 2. They have more of insulin resistance again and do well on insulin sensitizers. There are other specific types of diabetes, as I told you, the defect of the exocrine pancreas, mainly any type of fibrocalculous pancreatopathy, pancreatitis, trauma, neoplasia, fibrosis may all lead to this. Any endocrine disorders like Cushing syndrome, acromegaly, pheochromocytoma, wherever there is an increase of cortisol or hormones which increases the sugar may lead to this. There could be drug-induced diabetes by certain drugs like steroids. There could be other clinically defined groups also. What has changed from the previous classification? From type 1 and type 2, subclasses have been removed, and the rest of the remaining remains same. In terms of hybrid forms of diabetes, the slow evolving immune mediated form, the nomenclature has changed. Previously, they were known as LADA in the older classification. This has been now turned into this. The ketosis known is patients with ketosis and insulin deficiency, but is not, but later on may not require insulin, and it is not immune mediated, but no change compared to the previous one. In terms of monogenic, again, the newer one is updated nomenclature primarily, but no change much in terms of the other classifications that were present earlier. Unclassified diabetes is the new one which has been added in the new classification, which was not there earlier. It is used primarily to describe diabetes that does not clearly fit into other categories, mainly. Hypoglycemia first detected during pregnancy and gestational have been retained same, and they are not something that have not changed over a period of time. This is the ADA 2020 standard of care classification, which is repeated again this year in 2021, which the new standard of care has just come yesterday, which again more or less remains same. It classifies diabetes into type 1, which is mainly due to an autoimmune beta cell destruction leading to absolute insulin deficiency, and type 2, which is due to the progressive loss of beta cell secretion on the background of insulin resistance, and gestational diabetes, which is diagnosed in the second or third trimester of pregnancy, but not over diabetes prior to gestational, and specific types of diabetes due to other causes, which could be monogenic syndromes, so like neonatal and MODY, diseases of the exocrine pancreas, drug-induced per se, are the other come into the other types. This is the ADA classification per se. So to end, current classification per se does present a challenge to the diagnosis and treatment of patients with diabetes, partly mainly due to its conflicting and confounding definitions of type 1, type 2, and LADA. The current scheme also lacks a foundation that readily incorporates advances in understanding the disease and its treatment. The beta cell centric classification scheme was envisioned as a stimulus to guide basic research as well as clinical and translational search, and advances in understanding of the various pathological pathways and mechanisms leading to hyperglycemia and diabetes are needed per se in order to develop further classification systems. Thank you very much for your patient hearing.
Tejas sir, for such a great session.